Hello, and welcome to today's health webinar. This episode is brought to you by our friends at IMO Health. We would like to remind you that the Q&A feature is available, so feel free to send in your questions and comments throughout today's webinar. We would love to hear from you. And with that, I will turn it over to our moderator, Francesca Wutke.
Hi, everyone, and good morning and afternoon. I'm Francesca Wutke. I am leading the advisory team here at Health, and thanks so much for joining us today. Today, we're going to be talking about how clinical data is evolving from documentation to decision intelligence, and how clinically rich structured data is creating value beyond documentation. We have an amazing group of panelists who are going to share how they're using, structuring, and implementing data from their various perspectives with examples that connect clinical workflow with impact on care, reimbursement research, and AI. So with that, I'd love for them to introduce themselves, and then we'll get going with our discussion. Joe, would you like to go first?
Sure, happy to. Thank you everyone for joining us today, this afternoon, or this morning. My name is Joe Zabinski. I'm Senior Vice President of Product Management at IMO Health, where I oversee our life science portfolio. But I've been working in the space of health data, health informatics, basically anything that can be done to get meaning for patients and providers out of healthcare data for about a decade. My academic training is in epidemiology, large-scale data analysis. Looking forward to our conversation. Thank you.
Thanks, Joe. Matt, would you like to go next?
Yeah, hi, I'm Matt Whalen. I'm a colorectal surgeon with UCI Health and a physician and informaticist.
Tim?
Thanks, Francesca. Hey, everyone. My name's Tim Kessler. I'm the field CTO with Redox. Redox is a healthcare integration company where I've been helping power data flow for the last decade. And before joining Redox, I used to do implementations for Epic. So I've been working with healthcare data for quite a while now.
Excellent. And last but not least, Funke.
Good afternoon, and thank you for joining us. I am Funke Pickering. I am the Senior Medical Director at Inovalon. I'm also a health informaticist. My role sits at the intersection of medicine and technology, where I bring clinical realities into the software solutions that we develop for stakeholders across the ecosystem. So I'm really excited to get into this conversation today.
Wonderful. Well, thank you all for joining us. And maybe we'll start with asking our clinical experts what has changed the most in healthcare that is really driving more clinical data and what's making it more valuable today than it was even a few years back.
I can take that.
Go ahead.
I can get started with that. I think, thinking back initially to how we got here, we had the initial transition to EHR form paper with the kind of a top-down regulatory and federal regulations pushing for, meaningful use and things like that. And initially, our documentation was really around improving documentation, right? Reducing errors, tracking some clinical outcomes, right? Really around, compliance adoption. And what we've seen is actually the pendulum swing the other way, where now we're seeing technology is actually what's driving a lot of the change in itself. Think about how technology has transformed our banking system, right? And so now we have come to the intersection where we have been collecting data, and we're now, marrying that with the technological advancements that we have, and we're at a good point realizing that we're well positioned to really begin to harness the capabilities and insights that we can glean from the data that we've been collecting this whole time, right? And get real active intelligence. So I think we've seen the pendulum go from top down to where now we're realizing all the benefits that we can glean from the data we've been collecting, and that's pushing for a lot of innovation that we're seeing and more regulatory push up the pipeline.
Yeah, I think I echo a lot of that. The clinical documentation was to tell the patient's story. It was to communicate to your colleagues what your thought process was, what was going on. So the next person taking care of the patient really could know what was their story, what was their situation. And I think as technologies come in, it went from very sloppily, hastily written progress notes that many of you may have seen to ease, very easy to type, and these notes have become very verbose, and it's shifted away from clinically oriented notes now to becoming integrated within the health system, billing documents, research, outcomes. All this is driven off of that note. And so it's really shifted the burden of documentation from telling the patient's story to placing a lot of burden on the clinician to fill these other areas.
And you mentioned the burden of documentation. How can organizations, when they're implementing, this vast data source that we now have, how can they reduce that documentation burden while still capturing data that's really useful across the enterprise and surfacing what is the most useful?
I think there's a bunch of different strategies. There's so many data sources coming in a patient's encounter. It's coming in from our technology, our CT scans, our MRIs, our lab values, our clinicians, our ancillary services, physical therapy, occupational therapy, our nursing documentation. And there's so much redundant data within the system. And then it ultimately falls back onto the clinician to document it, because that's sort of the legal billing record. And so if we can harness these other data sources to facilitate that documentation, I think it's a huge win in decreasing the burden and burnout of the end clinician, letting the doctors get back to practicing medicine, letting the clinicians get back to practicing medicine as opposed to documenting the medicine.
And I'll add to that. I think for anyone in practice, the documentation burden is a topic anybody and everybody really wants to talk about. But I think some things become a burden when you don't see value or direct value in what you're doing. And a lot of clinicians who are in practice, you're documenting, you're not really getting the value out of what you're documenting. So you spend a lot of time collecting this, but you're not seeing the value of what you're doing. So I think there are three things to look at. I think one thing is efficiency, is make it easier for that documentation, just as Matt has said, right? Where reduce the redundancies and repetition, pull the data sources in and have it there when it's needed. And then also make the documentation meaningful to the person who's collecting the data, and make it reciprocal, right? I'm collecting the data, well, give me the insights that into the data that I am collecting. Right now, unfortunately, we still have data sitting in silos. And so getting that complete picture of a patient that you're looking at is still a challenge for a clinician, right? So we're all collecting data, but we're not getting that data in one place when we need it. And that where we need it needs to be at the point of care. So I think when you're implementing these strategies, it has to be, you got to focus on efficiency and making that data actionable at the point of care for the clinicians who are treating these patients.
So access to data, despite the plethora of data that exists, still remains a critical problem. What are some of the other challenges around data gaps in either in the clinic or in organizational practice that you're facing?
I could jump in with a comment on this, and curious for the other panelists' thoughts as well. But one of the ones that I perceive as a persistent gap with respect to data at the clinical side and the organizational side is this kind of tension between the specificity in which we can express what's going on with the patient and the need to do what Funke and Matt were just describing, which is bring disparate data to one place in a sort of harmonized way that can let folks use it without needing to duplicate documentation. And I think that's both a problem that's accelerated as personalized medicine has gotten more advanced and there's a need to document more specificity with respect to differences among patients, but also something where the value of keeping track of that specificity without sort of letting it fall off the rails has increased as well. So, I do see infrastructurally a gap in this sort of compromise that we often make, which is like, let's compress data to the lowest common denominator to make it interoperable. That makes the data interoperable, but it forces us to kind of push that specificity off the table entirely or relegate it to the places like, the physicians writing their notes, the places where they capture almost like that last line of defense of what do I actually need to say about this patient, which is not really optimal for anybody. I think we probably all have good ideas about how to solve that, but I do see that as an interesting challenge today.
And what are some of those good ideas to solve for that?
I think I could echo a bit of what Joe said here, because we've talked about access, we've talked about data silos, we've talked about kind of simplifying this content down to make it, easier to integrate and make accessible. But when I think about data accessibility and making it valuable, it's at the right place at the right time and the timeliness of that. So, avoiding kind of reducing that content down into a single line that makes it accessible, but ensuring that the right points of that data are landing in the clinician's workflow at the right place at the right time. So if you're getting kind of external clinical content about an individual patient, but it's coming 24 hours after the encounter, or, a week later in some cases, it's going to be far less valuable than if that's arriving, 30 minutes before that patient arrives for the encounter, or maybe while they're even in the ambulance on the way to the emergency department. Having some of that external content accessible in the systems you're working with today. And that's a lot of that comes down to just right place, right time. And that requires understanding the end user's workflows, the clinician's workflows, and how they're interacting with these tools.
Tim, that was a
Making
great
sure the
point.
right.
Sorry, go ahead.
Please, Matt. No, please.
I was going to say, with fragmentation of care, this becomes an even bigger burden. I'm very fortunate. I work at a major academic medical center in Southern California. And so when my patients are in my system, I have every little bit of data from every clinician they've ever seen at my fingertips. But I get a lot of outside referrals, and those come from other health systems. They come from private practice, physicians who are still faxing me records. So I'm a colorectal surgeon. I get a lot of endoscopy reports. I still get black and white faxed colonoscopy reports to my office. That is of little help to me. Now, I appreciate the descriptions that are there, but how do we harness that? How do we bring that information in and then make it accessible, like Tim said? Like, I want that information in my hands when I'm seeing the patient, easily to find versus kind of searching through the EMR. We accept these transfer patients in from other hospitals, and I can't see their imaging when they come to my hospital, or when I'm discussing with the referring docs for transfer requests. And so that increases a lot of redundancy, wasted cost, because they get to my hospital, I've got to make a decision in the next hour whether they need to go to the operating room or not. So they're getting redundant scans when they just had one, but it didn't come over with them. So I think that getting the right data in the hands of the clinicians in a timely fashion in the right way really is important.
Yeah, if I can add to that, I think one thing a couple of folks touched on is also a disparity, I guess, in language, right? Everybody communicates, clinicians document in natural language. And within, using natural language, you have the semantics and the nuances and context, or say the arts, right, of the practice of medicine, and that's captured in natural language. How do we take that, translate it into machine readable formats so that we can then make that interoperable and communicate, send that information to the next clinician without losing the context, the nuance that is supposed to have been originally intended? I'll give you an example. You have an ICD-10 for back pain, right? The same, you might have two different patients, two different scenarios, where one patient is describing, aching lower back pain, and you have the same ICD-10 code as you would if somebody comes and says, okay, I have shooting sharp back pain, extending down my leg. As I'm saying that, clinicians are thinking about two different clinical diagnoses, right? But sometimes we lose that context in making that, translation. And that's a major challenge where, especially where I sit there, is what we try and tackle a lot. It's like you're sending clinical context that has real clinical implication. We need to make sure that we're not losing the context in that translation.
So it sounds like there are multiple buckets of challenges that you're all seeing, that translational problem where the syntax may or may not be maintained, and that can impact how you treat that patient. The other piece is very siloed data. How do we build the plumbing to transfer that data from one place to another, so that when a patient presents to you, they have a complete view of their history and their prior care. There's massive cost savings in that as well. As you said, Matt, you don't have to redo scans if the scans that were done are available for you to see. So there are some structural changes around how we would implement, data access across those areas, but also maintaining the right language and level of context in order to really action the data that are there. Where do you see opportunities for really clinically rich structured data to improve care and reimbursement research or even AI? It's very broad, but we can kind of take it in smaller bits.
Yeah, I would say, picking up on something Funke was just describing about context. I think all of those items that you just mentioned, Francesca, care, reimbursement, research, even AI applications, what they all can benefit from is understanding more of the context around the just individual descriptors we have of what's going on. And for so long, those individual descriptors, whether it's on the research side or at the bedside, are sort of what we index off of, right? We have those codes, like the back pain code, and that gives us a little bit of a flavor, but it doesn't give us that context. If we can have technical systems that persist more of the context, more of the understanding of what's going on with the patient, I think the benefits to all of those areas are significant. And the ones that stand out most significantly to me are sort of a collapsing of the space between what's actually going on with the patient's condition and treatment. So, for example, like a medication they may need, and the processes that inform that, right? Things like prior authorization, reimbursement, making sure that there's no conflicts in the patient's, different conditions that are being managed. All of those are questions of context. And if we can maintain that context, I think we can collapse a lot of the friction that we all, experience in different ways in dealing with the healthcare system, where a lot of times it's just literally people on two ends of the phone have different understandings, right? If we can just give them the same understanding, a lot of that friction collapses.
And it seems like in streamlining a lot of these data assets, on the one hand, where we're reducing it down to a specific code or a specific diagnosis, but then there are times when we want to get into that granularity and understand more of the context around where that patient is actually sitting within their healthcare journey. So that seems a bit of a challenge, because at the same time we have to get very, very specific, very broad, and then granular again, and then maintaining that the same level of syntax throughout, so that a back pain coming from two different patients isn't perceived or treated in the same way, even though some of the codes and the nomenclature around their how they're presenting may be the same. Any other opportunities where structured data can really add to patient benefit?
From my perspective, I'm taking it a little bit kind of on the population level. I spent a lot of my clinical time working with high-risk populations. And I think this would be, high-risk, underserved populations, lend itself to be, that's a big area of opportunity, right? For understanding the needs of a population and to reach them better and improve outcomes. So in terms of, I was thinking about this particular question in terms of populations, and the underserved high-risk populations that typically don't engage or as much with the traditional healthcare setting, or that the traditional kind of in-office visits don't work for them well, and they kind of fall through the cracks. And so they are the ones that tend to end up showing up in the emergency room, have poor outcomes, and we always struggle to try and reach. I think trying to understand this population is where we can kind of leverage the clinically rich data to improve outcomes there. And then the other population I was thinking about is hard to find group of patients, where you're talking about rare conditions, rare diseases, especially when we're thinking about, a life sciences industry, where we're looking at folks we're trying to gather or recruit for clinical research, for various reasons, right? When you have people with rare diseases that are just scattered around the country, and where, the data on these diseases are really hard to get our hands on and, correlate together, so we can really glean the insights that we need and inform research, treatments, and even start to model, patients like me, right? I think particularly around rare diseases, there's a lot of opportunity that we can hear and that we can really leverage our data and for research, and especially with the advent and layering on interoperability and accelerating with AI.
I agree
Yeah,
with
absolutely.
everyone's comments. If I can just jump in. So I think,
Please.
the data telling the story of the patient, when we go in as clinicians and look at the patient, we can kind of tell how sick they are. But it's sometimes it's challenging to code that. We're sort of addressing and documenting the relevant items at that time, but we always joke, oh, I take care of the sickest patients, that's why my length of stay is longer. Well, how do we actually justify that from a health system? How do I justify my outcomes? If I'm taking care of very sick patients or very straightforward patients, I have to sort of document and tell that story to justify my outcome differences or my length of stay differences. And from a healthcare system, reimbursements, DRG. And so I think anytime we can get information that's within the system in front of the physician, in front of the clinician, so that they can be prompted to diagnose it, right? You're missing these potential diagnosis codes, which really tell them more of the story of how complicated what you took care of really was, helps them, right? Without getting the inquiries in our inbox all the time of, did you want to document this? That comes in after hours or after the patient's been discharged a week. And so if we can help streamline that data and get that information in front of them, I think it helps. It helps from revenue. It helps from outcomes. It can be used for prediction. Where are patients on their curve? What sort of alarms should we be looking at? This patient is developing signs of sepsis, early detection kind of systems that are being developed. And then also from research standpoint, which was mentioned, randomized controlled trials are wildly expensive to run. They're great. That's how we really can get outcomes. But we have so much retrospective data out there in these massive data sets. But how do we really know? How are we comparing apples to apples? We have so many data points within these databases, within these systems. We need to be able to kind of compare apples to apples. You were talking about back pain. How do we really compare back pain A to back pain B and know that they are the same things and really make that retrospective data more relevant?
Yeah, the only thing I'd add here is really hammering what Matt mentioned here briefly and doubling down on right data at the right place at the right time. If a patient's discharged from an inpatient stay, we document their primary care information at the point of admission. How can we not leveraging real-time integration, we can notify the primary care provider, hey, your patient was just discharged. Let's grab the clinical record from that encounter, get that to the primary care provider, and then push that nudge to get a visit, an outpatient visit with that patient, within a week or two post-discharge, so that you can actually get them adhering to their care plan, kind of intervening in those scenarios and helping reduce some of the readmission rates that you might see, when patients are discharged, but their next actual encounter with a provider is unfortunately 3 months later when they're back in the emergency department for the same issue. So I really kind of double down on this right data at the right place at the right time, because now that we have all this content structured, it's about actually making it usable by putting it in the right hands of the right people in a timely manner.
Yeah, I love that. I would love that sort of like integrated dissemination of information and then say, yeah. Hey, primary care doc, here's my cell phone number. Call me if you have questions about this patient. Then we can have a dialogue. We've lost this. We've lost this person-to-person communication so much because of all the modalities of communication we have. There's nothing better than picking up the phone and having a conversation to really kind of paint the picture.
I mean, we ask patient access users to document all of this upon patient arrival. Clinicians are documenting all of this during the encounter. And then we seemingly decide faxing it's the best way. So it's all digitized. It's all there. But for some reason, I mean, if you don't work in healthcare, I think you'd be shocked at the amount of faxing that still exists in this space. But it's we can get to some of that stuff when we get to the AI questions. But yeah, it's wild. And it's all there. We just have to make use of it and get it in the right place at the right time.
One thing I just wanted to pick up on that you both mentioned, but okay, you started about talking about the patient populations that are underserved or people with rare diseases. There are also loads and loads of patients that are presenting with really complex, seemingly disparate symptoms and problems and complications. And one of the things that AI does really, really well is pattern recognition. So if we're able to kind of look across, from a population health perspective, see how those same patterns are being manifested in other patients, and deciding, how to treat them, and what works, obviously in a way that's HIPAA compliant, and de-identifying data. But have you seen in practice examples where either a difficult to treat patient, or a patient with a rare disease have benefited from a shorter time to diagnosis as a result of better access to data?
I can say I've seen this happen in
Go ahead.
report, but Funke could or Matt could describe it in their own practice, perhaps. I mean, absolutely. When Funke was mentioning rare disease, when I've worked in rare disease epidemiology research, one of the most powerful things that we can do using data sets and high power algorithms is to say this patient already looks like they're 8 steps down the 12-step diagnostic journey towards this particular rare condition, that it's not an exercise in blaming no one for realizing that yet. It's there's a reason that obscure diagnosis is very far down the differential list, but they deserve a second look because of this body of evidence. Let's get them a second look. And I have seen real cases where that kind of thing has accelerated diagnosis. It requires summarizing that information, checking it against, all the statistical likelihoods of what it could mean, and then looping it into the point of care. But yeah, I have seen this happen in real life. Never at scale yet. I mean, that's the dream I have for these things. But I've certainly seen it work.
Yeah, Joe, that's
But
a
it's great that those
Yeah.
kernels are coming up.
No, I think it's really, you kind of hit it on the head. You've got these complex patients, and we read the textbooks, but that was 15 years plus ago that I read that in a textbook. It's way back in the memory, and so our mind isn't necessarily going to see or think about something unless it's kind of active in our thought process. And so coming up with those rare differentials, I think, can be very helpful. A lot of this is what happens on the day to day. Hey, Funke, I've got a really sick patient. I'm not really sure what's going on. We have these dialogues in the lounge or in the hallway or wherever it may be. You kind of talk to your colleagues about the situation, and they can render their advice or their thoughts. But having that sort of like consult, that digital consult, if you will, to help point you in the right direction. Have you considered these other diagnoses? I think would be a huge benefit.
And to Matt's point, right, when it comes to rare diseases, right, it typically takes about 5 to 70 years in some cases for these patients to be diagnosed. So it's a long road for them. And unfortunately, as Matt said, some of these conditions we may never, a physician may see once or encounter once, or maybe never during their career. But having access to, connected and complete data longitudinally, right? When you're there, you're seeing the patient and trying to figure out, what's going on with this person. It would be helpful to know, years ago, 2 years ago, maybe they had, their ears were blowing up or something like that, or they had joint pain. And then it helps you connect the dots. And especially when you put all of that together and then can have the analytics of the point of care, the AI that, as you said, the pattern recognition. It's better when you have the complete story so they can actually glean the insights you're trying to get at and connect the dots better, right? But if the data you have is not even complete, right, you might not have the complete picture to put it all together. So, having all of that in one place is helpful to help accelerate that. I'm hoping that in 5 years from now we'll, be able to cut that time down to a year or two or even less. But I think we also, as we've said before, it's really trying to empower the physicians with the knowledge that they need while the patient is in front of them.
And if I could just chime in on one thing that you said that it just made me think of something. It was, a change that occurred a long time ago in a patient. And I think one thing that we will see in patients with chronic disease, it becomes their normal. And so if you're seeing them 5, 10 years into their disease course, they may not even mention that symptom to you because it's part of their daily life. It's become so ingrained in them. And so unless you are specifically asking for certain things, or you're looking for these, esoteric or strange context cues, it may not be something that they even mention when you're doing your history with them. But if you can, resource some change in documentation that occurred in the past, and you're not going to have the time or the resources to go back 15 years into their charts. But with AI, with digital technology and whatnot, we can harness that, and it will detect those changes and bring it to the forefront. So I just wanted to piggyback on what you said about that.
And that's an interesting point about, the types of questions that you're asking of the patients and the kind of information that they're offering to you. What role does something like, terminology or knowledge graphs and even interoperability play in making the clinical data that you do have at your disposal really usable?
I mean, this one, reaches my heart because at IMO, we spend a lot of time thinking about terminology, but really as a gateway to allow people to express what they mean, most especially clinicians. So, having an ability to interact with any information system in a way that can capture what you actually want to say, I think is sort of the table stakes here. And again, this is most often the question of the clinicians where they know what they want to say. We just have to give them a way to say it. That's what we at IMO spend a lot of our time doing. The other one that strikes me in that question, Francesca, is this question of knowledge graphs, which folks may be familiar with. One of the many tools that people have to allow for information interconnectedness and governance, especially with AI. Really, the idea is, I actually wrote down Matt's quote before, integrated dissemination of information. I like that way of expressing. A knowledge graph can do that because it just says, here's what you wanted to say, and here's how it's all connected to everything else in a governed way, right? We know that this medication connects to this diagnosis because it's FDA approved, or maybe because a trial, provided that evidence. We know that this symptom is associated with this potential, condition. Those kinds of ways of connecting information are not old, rather not new academically, but I think they're new in application because, moving away from a world of kind of storing information in these flattened, compressed, siloed table systems that we're all familiar with into something that's much more living, much more interactive, that can, be used to ask questions like, what information am I missing, right? What would help me have a more complete picture of what's going on? A knowledge graph can actually answer that and say, if you go do this test, or if you ask this question, or if you answer, this piece of information, we can help figure out what's going on. That kind of thing, I think is helpful at point of care, but also in clarifying a lot of the research use cases and the other cases we've been discussing. So those tools are ones I'm very excited about to solve some of the problems that we've been discussing here.
And Joe, for those that are maybe not as knowledgeable, can you describe and define what a knowledge graph is for our audience?
Sure. The dangerous question. I did my doctoral dissertation on graphs, so I'll truncate myself, but
in a minute or less.
Yeah, no, I promise I'll be quick, and I'd love to let others speak as well. But a knowledge graph is just a structure that can capture different kinds of information and show interactions among those kinds of information in a way that can be used for reasoning and other applications. So those we talk about graphs with nodes and edges. Nodes are like if you picture almost like a molecule, right? There's those balls inside. Those nodes are any discrete piece of information you want. So it could be a diagnosis code, it could be a medication, it could be a procedure, it could be a patient demographic characteristic, any of those kinds of things. The edges, the connections, are just literally the connections among those pieces of information. So if you imagine, saying, I've got a bunch of information about a patient, some demographics, some lab results, some diagnoses, graph, tell me what this means with respect to treatment protocols, right? For example, an oncology patient. A graph should be able to say, okay, based on those facts and the rules that I know about that have come from, guidelines around treating lung cancer, prostate cancer, whatever, here's what the options are for this patient. And you can keep going with this. You can say, well, what if I do X? How will that change? Or if I don't know Y, will that give a different answer, right? Those are reasoning versions of the graph. But in a nutshell, that's what graphs are. Hopefully I did it justice without rambling.
Thank you. That's great. So it's a decision tree on steroids with
oh, I like that.
Backed by evidence and actual data. So Great. Thank you
Provenance
for that, Jeff.
specific decision tree. Yeah, there you go.
Great. And how are all of you thinking about the use of AI tools in healthcare workflows, especially from a governance perspective? I think all of you have touched on governance to different degrees, but it would be interesting to get your views on that.
There's so many areas.
I think
We all have
Okay,
a
go
pause
first.
beforehand.
go ahead, Tim.
I was
Who's
going
gonna
to
be
say,
the
we're
first
all,
to
we're all
jump
just
in?
waiting to
Trying
jump
to
in. But okay, I'll let you go first because I think it's probably best we start more on the clinical side and we can go more into administrative operational. So I'll pass to you first.
Okay. Well, I think with AI, I think about this like physician first, right? Like any other tool that you use in healthcare. You think about the responsibility you have and decisions you have to make. And if you're going to use any tool, you think, well, can I trust this? Is this reliable, right? And so the same thing applies with AI, right? There's a level of trust that we're still trying to, I guess, build. And that requires, I think that's where governance needs to focus, especially in the healthcare space. It's not surprising why physicians and clinicians tend to be late adopters when it comes to technology, right? We want to make sure it's tried and true and tested properly before we even try to think about using it on our patients, because we're very, very risk averse because we're talking about life and death and people's way of life, right? So I think when it comes to governance, the focus should be on transparency and then auditability. And I cannot, maybe a broken record here, but I'm always human in the loop in the design. And I think without these three elements, we will continue to face challenges in how AI is not only used in creating solutions, but more importantly, how it's adopted and how we engage the end users in using these solutions.
Yeah, I think, or sorry, Matt, go ahead.
No, go ahead, Tim, please.
I was going to say, I think Funke hit a lot of the key points here. Human in the loop, ensuring there's a kind of scenario where if you're not 100% certain that this is correct, route it to a default pool or something. One of the largest AI scenarios, we've deployed recently is we're genuinely just reading faxes and then routing them to the right location. But if we can't say confidently that this is XYZ type of fax, this is a medication refill request or a referral request, we route it to a human reviewed tool. We have fallback scenarios where these can be routed to other locations, or if something is incorrectly routed, you can reclassify things. And I think at this stage in the AI journey, definitely think about the human in the loop scenarios, definitely think about the failure scenarios, and ensure that, I often highlight too that I think a lot of the best scenarios are, how can we enable this to cut back on a lot of the administrative burden? How can we enable this, for example, ambient listening tools to reduce the amount of actual documentation that providers need to do? Now, of course, you still want them reviewing those notes before they finalize into the patient's chart. But there are so many areas where the HITECH Act meaningful use and EHR adoption led to significantly more work on our clinicians' plate. And we can, if we're going to start with AI somewhere in the workflow, I think let's focus on how do we reduce the burden that we've put on all our healthcare workers to actually document to ensure charges and bills go out successfully, rather than saying, this AI can guide a clinician's hand through a surgery. That may be 40 years from 10, 20, 30, 40 years from now, but there's so many areas from an administrative burden perspective that can massively free up our providers and clinicians to do other things with, and actually with the patient rather than with their software.
Yeah, Tim, that was great. So I'm going to put on my clinician hat for a second. And, I am the most expensive data entry personnel in a enterprise, right?
Yeah.
Truthfully. And so I think the ambient listening technology, the note generation technology really is what's going to capture the clinician. My ability to walk in, sit down with a patient, put on a recording device, tell them I'm doing so, and just talk to them, engage with the patient, right? Eye-to-eye contact. I'm not sitting behind my screen, typing away, typing over their speech that's very soft. It allows that human approach that we all went into medicine for. We're able to reconnect to the patient, and I love that. We absolutely have to review our notes. but maybe I'm not the best coder. I didn't go to med school to learn how to do, medical billing and coding. And so, like you mentioned, the pre-authorizations, making sure I have the right diagnosis for the right procedures, that's where AI can really help nudge us, give us suggestions. Hey, that procedure that you wrote for isn't going to be authorized because of their insurance company. You need to think about these other diagnoses, which we detected, in your conversation with the patient. That sort of aspect, I think, is really what's going to capture the end user, which is the physician. And then also we have to make it easy. I remember having senior colleagues who, quite frankly, struggled to document or put in orders in Epic. And we need to make this easy, whether it's be suggestions, plug and play, at the elbow support. Prompt development is fantastic, but you could lose hours in doing so and trying to train your AI ambient listening tool. And so we really have to have, you are this kind of physician, you like your notes to look like this. Here's how we suggest setting this up, and really make it plug and play for the end user so they're not losing hours of time and setup on the front end. And that's going to increase adoption, in my opinion.
That's great. I think that's a super complete answer, and I think what we're all kind of trying to get at. I love that your characterization is the most expensive data entry person. I think that definitely resonates. What would you say is a practical step that the healthcare organizations can take now to turn documentation into more actionable intelligence rather than having very expensive data entry folks populating these data sets?
I mean, my favorite answer here is to just take advantage of what's already documented. Don't start by asking people to do more. Just sometimes I describe this as squeezing all the juice you can out of the orange. It's already in there. Let's let the folks whose job it is to worry about squeezing that juice do stuff, and not ask our clinicians to change workflows or to add more time. My wife is a clinician. She spends a lot of nights coding, writing up documentation. We don't want to do that. For example, Matt, you just made me think of one thing we've started helping our healthcare partners do this year, which is just when an expensive and high denial rate medication gets prescribed, we can help check that medications against the patient's payer approval policies to say, is this lined up? Are you going to face a denial, right? Provider doesn't have to do anything else to kind of run that. And we can pop up something that says, here's the gaps, we're not asking you to change anything, but just letting you know if there is a gap, here's what it is. The goal, I think, in any of those kinds of things, very practically for a healthcare organization, is to just interrogate what is actually there. What are we capturing? It's probably a lot richer than is being utilized. And let's start with that before we go into anything further. That's my one quick trick.
That's
Yeah,
great.
I think if we're looking practical actions here, actually pay attention to the workflow. If you're building a solution for a healthcare ecosystem and you're looking to design integration around it, don't just say, these are the data points I need. Actually understand the end users who might be leveraging your product and understand the workflow they're going through and where that data needs to land in their system to be useful. I mean, if the outcome is a provider having to copy and paste something to drop it into their chart, like you've already created a lot more steps that are just going to add a ton of friction. So really understand the steps your users are taking, understand the steps that the clinicians interacting with your platform are taking, and focus on that.
I absolutely love, Tim, what you just said, because especially when you're trying to create a solution for someone in practice, you have to be very careful that you're not creating a separate or a new problem with the solution, more work. And it's really important, as you said, to pay attention to the workflow. So it's important you're speaking with those people who are there treating the patients. Absolutely.
Yeah, I think, what Joe, Tim, and Funky said were all very true. I think the more we can get things happening on the front end will be helpful. So I don't know how many people have seen what a prior authorization or a insurance appeal looks like, but you could spend 30 minutes to an hour on the phone waiting for someone to answer or going through a phone tree. And so being able to sort of like head that off at the pass, like Joe said, when you're requesting a medication, knowing that, oh man, if I put this in, I'm going to have to call and get the reviewer on the phone and explain it, or I'm going to have to submit a bunch of more documentation. I want to take care of that patient, take care of their documentation, and move on to the next patient or the next thing I have in my day. And so the more we can get these interactions up front, not having to go back and answer the CDI inquiry because it was, anemia of chronic disease, and I just wrote anemia in my chart. Hey, hang on, you wrote anemia, prompt right away. Are these areas where, is it fill one of these? Because it's going to generate a query on the back end. And I think that's going to reduce the burnout. And that's going to increase satisfaction.
Matt, when you call today, are you even getting a person after 30 minutes, or is it just an AI from the payer picking up the phone?
They sounded pretty real last time
Okay, good.
But yeah, it's a good question. It's a really good question.
I'm worried because I think that's coming. So we'll see.
Maybe we could have our AI talk to their AI and, sort it out.
Believe it or not, we're already doing that for some partners on the back end for claim downgrades and kind of denials on the back end, because payers are using AI to generate those. So providers should use AI to fight them.
Absolutely.
Maybe they can at least talk really fast.
Yep.
I want to leave some time for some questions from our audience, because we've gotten some great ones. So the first is, how do you go about making sure that the data being shared with clinicians is correct and that mistakes don't kind of make their way in there?
It's a great question. Garbage in, garbage out.
Yeah.
And we will see the lies within the copy forward charts, right? And I use the word lies, but it's more incorrect information. You'll see something documented, and then it just becomes pervasive in the medical record. And I think we have to make sure good data entry at the front end and accurate data is actually being put into the system. I think that's where we start. I'll let everyone else kind of chime in, but it's got to be good validated data going in.
Yeah, I mean, traditionally, we could source or we could know where data came from, even if, there was an issue with some of the garbage inputs. We could at least kind of put our finger on why they were in there. The thing that scares me most with this question is, as AI becomes more pervasive in advance of its governance, I think we're starting to see hallucinations creep their way into records sometimes. I've heard this from CMIOs. I've heard it from physicians. And that one's really tough because it can be very hard to ferret out that a piece of information is false if it was hallucinated and then copied forward and so it sort of worms its way in. The answer to that, I think, is really clamping guardrails on any AI system that's allowed to interact with the patient record so that it can't hallucinate beyond the bounds of what's permitted. But those guardrails, they exist, but they've not been implemented everywhere. And that's when I think folks have to watch out for very carefully right now.
I was just going to add, I think this is where even knowledge graphs can help when it comes to AI, because it's important that the models that we're using are actually grounded in medical facts, and we having knowledge graphs that are built based on this and guidelines, clinical guidelines and recommendation, sets a foundation to reduce those kind of hallucinations that you might see with AI. So it's important to kind of to look at how these models are, what's the models that are being used for this. The other piece I was going to say in terms of making sure it's the right patient, there are matching logic to make sure you're sending the right data about the person. But here's another piece that I brought up when it comes to data and AI also is the transparency piece. Not only do we know where the data is coming from, but I think transparency to the patients. So allowing patients to see, so that, keep track. If you do see something in your chart that doesn't make sense, I think we should pull in and not forget to carry along the patients in this journey as well. So they are also part of the conversation, and also keeping track of something doesn't look right in the chart. They can also, provide that feedback. So I think we all have part of this work to do. And I think patients also need to be engaged as we go along with this.
Yeah, I think the only thing I'd highlight here is data provenance, understanding the source, where that data is coming from, ensuring that provenance content is persisted and tracked through that data as it flows through the integration. And then also, I see a lot of groups trying to automate the reconciliation of this data and saying, okay, well, based on this data and this data, we can assume this is true. And it's like, look, there's a reason like clinicians should be reconciling this data with the patient as it comes in some cases. So yes, it's valuable to have this content provided to the clinician at the point of care where they're meeting with the patient, but don't necessarily auto drop that into the chart and just assume that that's the truth, especially if this is a lot of external content coming from other sources. Give the provider, the clinicians an opportunity to reconcile and before adding that directly to the chart.
And on that, how should we think about clinical liability in the world of AI-led decision making? And should it be AI-led decision making?
Is anyone here a lawyer?
Nope.
Oh,
I play
man.
one at home. I'm not one. But, I've come across this. This is something I think a lot of physicians have in the back of their mind, right? Because at the end of the day, you are ultimately responsible for the tool that you use, AI or not, right? And so, again, this is where the trust needs to be a big focus point when we're building these solutions, as well as transparency and auditability, right? So, unfortunately, until we really sorted out this question in terms of where liability really lays, right now the liability is on the end user, the clinician. And as such, think adding that onto the responsibility of treating your patients and that kind of consideration, the physicians have a lot more to think about on their plate when they're thinking about AI tools. So it's not as easily it's not easy to just go ahead and say, I'm going to adopt and start using these tools, because you do know that at the end of the day, the liability is on you.
I agree. I think as an end user, we have to think of this as a tool, just like looking at a study that's published in whatever journal. We have to go back and critique that. We have to be able to go back and critically look at that data and say, is this real? Does this actually fit? We can't just blindly turn off our brains and let the machines do the work for us, right? We might as well just give away our jobs at that point in time. So ultimately, patients will come in, they have Googled their things, they're convinced they come in with a diagnosis, but you have to take in the experience of the clinician as well as their knowledge. Not to discount, looking into your own chart or the data that's there, but you have to put it in the whole context of the patient. And so I think using it as a tool is really fantastic. It's a great tool, but we have to be critical of the data and really take it into the whole context and not just take it at face value.
And in the cases where the data itself is ambiguous and uncertain, are there current AI solutions for that to demystify data that might be confusing?
There's certainly different kinds of solutions I'm aware of to help resolve ambiguity. I'll caveat that immediately by saying sometimes it's not even appropriate to resolve all ambiguity because one person might think something's perfectly clear for their use, where another might say I need much more detail. But certainly, integrated systems, again, in the way we've been discussing, that can detect ambiguity and prompt in the gentlest way possible at its source to say, can you clarify, did you mean this or that? That can be very helpful and solve a lot of downstream problems. The other solutions that involve more AI and that are quite cool technologically are really getting back to that point. There are things like saying, based on everything else we know about this patient, what is most likely to be true with respect to resolution of that ambiguity, A or B? And I'm a big fan and defender of those kinds of systems, but there's those probabilistic ways of doing it. And then there's the ones in the workflow that just say, hey, we've detected, that this could do with some resolution and clarity. Let's capture it before we miss it. Those are, I think, the two ways to answer that question.
Great. And maybe we'll take one last question about how data can be used for research purposes, kind of mapping it to different data models for research analytics. Is anyone working to get the clinical EHR data mapped to this model, at the time of data creation by using AI tools or other data translation tools?
Yeah, I think either Joe or I could take this one because this
That's
is
our
day
next
in and day.
webinar, Tim.
Yeah, I was going to say this is day in, day out of work we do. Redox automates this. We take HL7 data into FHIR or OMOP left and right. I know we actually work really closely with IMO for automating some of the enrichment. So, if one code set comes out, we can actually automatically query out to IMO to enrich that code set before dropping into the research database. Because you got to think about consistent format of the standards. So, FHIR versus OMOP versus other different formats. But you also got to think of the content within those. If you're working with data from 10 different healthcare organizations that use 10 different EHRs, suddenly data in the same field from one system might look radically different from the data at another organization in that same field. So thinking about not just translating the format, which we do day in and day out, and we have AI tools in our platform to help users in Redox do that more simply. But also think about the terminology, the content, and what's being done to make sure that when you get all that data in your single environment, where you want to, in that OMOP format, to run your research, that it actually all aligns and makes sense. And that often stems from, as soon as you set up the initial ingestion of that data from the source system, ensuring that you understand that data, you understand the context of that data, and you understand the site-specific variations that are being applied to that. And then you have the tooling to help you convert and translate that into a format that you can actually work with. And that's where Redox and IMO come in left and right.
Said it beautifully, Tim.
Well, thank you. Maybe that's a good place for us to pause here. I want to thank the panel for their amazing expertise and answers to the questions. Thanks to the audience for listening and learning, and for all the questions you posed as well, and to our sponsor, IMO Health. So thanks so much, and look forward to seeing you again soon.
Thank you to IMO Health and to everyone that joined us today. Please visit our website, HLTH.com, to catch up on all health webinars and watch the recording of today's session. Join us in Amsterdam, June 15th to 18th for Health Europe,